The anal sphincter is a complex structure responsible for controlling defecation and maintaining continence. It consists of the internal anal sphincter and the external anal sphincter, along with associated anatomical features. Here's a detailed enumeration. 1. Internal anal sphincter. Type: involuntary, smooth muscle. Location: forms the inner circular layer of the anal canal's muscular wall. Function: maintains baseline tone to prevent leakage and relaxes during defecation under autonomic control, primarily parasympathetic via pelvic nerves and sympathetic via hypogastric nerves. 2. External anal sphincter. Type: voluntary, skeletal muscle. Subdivisions: subcutaneous portion, the most distal part, located near the anal verge. Superficial portion, anchored to the coccyx posteriorly and the perineal body anteriorly. Deep portion, surrounds the anal canal and blends with the puborectalis muscle. Function: provides voluntary control over defecation innervated by the pudendal nerve. 3. Associated structures. Puborectalis muscle, part of the levator ani group, forms a sling around the rectum, creating the anorectal angle that aids in continence. Anal cushions, vascular cushions located at the 3, 7, and 11 o'clock positions in lithotomy position, contribute to sealing the anal canal during rest. Intermuscular groove, Hilton's line, separates the internal and external anal sphincters. Pectinate line, anatomical landmark dividing the upper 2/3 endodermal and lower third ectodermal of the anal canal, relevant for vascular and nerve supply differences. 4. Nerve supply, internal anal sphincter, autonomic, sympathetic, and parasympathetic. External anal sphincter, somatic, pudendal nerve, S2 to S4. Nerve 5. Blood supply. Superior rectal artery supplies the upper anal canal. Middle and inferior rectal arteries supply the lower anal canal and sphincters. This coordinated structure allows both voluntary and involuntary control of bowel movements. Fecal incontinence, FI, the inability to control bowel movements, ranges in severity and may significantly impact quality of life. Below is a detailed outline of fecal incontinence and its treatments. Types of fecal incontinence. 1. Urge incontinence, inability to control bowel movements despite feeling the need to defecate. 2. Passive incontinence, unawareness of stool passage, often due to reduced sensation. 3. Overflow incontinence, leakage of liquid stool around impacted feces, often associated with chronic constipation. Causes. 1. Anal sphincter dysfunction, weakening or damage to the internal or external anal sphincter. 2. Neurological issues, damage to nerves, e.g. due to diabetes, spinal cord injury, or multiple sclerosis. 3. Rectal abnormalities, decreased rectal compliance or sensation. 4. Chronic diarrhea or constipation. 5. Trauma, often related to childbirth or pelvic surgery. 6. Aging, reduced anal tone and sensation. 7. Other conditions, rectal prolapse, inflammatory bowel disease, or irritable bowel syndrome. Diagnosis. 1. Clinical history and physical examination to assess severity and identify contributing factors. 2. Anorectal manometry measures anal sphincter pressure and rectal sensation. 3. Endoanal ultrasound evaluates structural damage to the anal sphincter. 4. Defecography, X-ray or MRI to assess rectal and anal anatomy during defecation. 5. Neurological tests to identify nerve damage. Treatment options. Conservative measures. 1. Dietary modifications. Increase fiber intake to improve stool consistency. Avoid trigger foods, e.g. caffeine, artificial sweeteners, spicy foods. 2. Medications. Anti-diarrheal agents, e.g. loperamide or diphenoxylate atropine. Fiber supplements to bulk stools, e.g. psyllium or methylcellulose. Laxatives for overflow incontinence due to constipation. 3. Bowel training. Establish a regular defecation schedule to improve bowel habits. 4. Pelvic floor exercises. Kegel exercises strengthen the pelvic floor and anal sphincter muscles. Biofeedback therapy assists in improving muscle control and sensation. Minimally invasive therapies. 1. Sacral nerve stimulation, SNS, involves placing a small device under the skin to stimulate sacral nerves controlling bowel function, effective for moderate to severe cases. 2. Injectable bulking agents. Substances like silicone or collagen are injected into the anal sphincter to improve closure. Surgical interventions. 1. Sphincteroplasty, repairs torn or weakened anal sphincter muscles, often due to childbirth. 2. Artificial bowel sphincter, implantation of a device to control anal opening and closure. 3. Colostomy, creating a stoma opening in the abdomen to divert stool, reserved for severe cases when other treatments fail. 4. Graciloplasty, using a muscle graft, e.g., gracilis muscle from the thigh, to reinforce the sphincter. Emerging treatments. 1. Stem cell therapy, experimental approaches to regenerate damaged anal sphincter muscles. 2. Magnetic anal sphincter, a ring of magnets implanted around the anal sphincter to improve closure. Prognosis. The success of treatment varies depending on the underlying cause, severity, and patient adherence to therapy. Multimodal approaches, combining conservative and advanced therapies, often yield the best outcomes. Prevention. Maintain bowel regularity through diet and hydration. Prompt treatment of diarrhea or constipation. Strengthen pelvic floor muscles, especially after childbirth. If symptoms persist or worsen, consultation with a gastroenterologist or colorectal specialist is recommended.